So appropriate shoes, non-steroidal, both oral and topical, program of calf stretching, because again, the vast majority of them have quietness that needs to be dealt with. And if they're not at least 50% better with your simple stuff, then it's absolutely reasonable to then go on. So duration of condition of the heel pain is definitely important. I always say to people, I don't care what the condition is, and it can be frustrating at times because they'll do this, but show me with one finger where it hurts the most. If I could take away your worst pain, whatever it is, whether it's heel spur or anything else, show me with one finger where I'd take that pain away from. And sometimes it's oftentimes worth being persistent with that and, looking at them and saying, and if they still keep doing this, give them your pen and say, just show me with this. So it forces them to have to show something. That's been helpful. It doesn't always work, but a lot of times it'll get them to focus in on where the pain is, and then you can focus in on your assessment. So show me with one finger is worth a lot. The frequency of the pain should be an idea, a concept you need to get an idea about. Because I'm surprised sometimes that people come to see me for reconstructive surgery, and it hurts once every 3 months. Okay, so I'm really going to operate on this, you know what I mean? And the same thing with heel spur as well. So these concepts are going to apply no matter what the condition is. The frequency of the treatment of the condition, and you need to be making a note of this in your record so you can look back at that afterwards. What activities do you do and what makes it worse? And how that relates, that's important as well. Most people with heel spur, it's painful after activity, and the classic sign, of course, is orthostatic dyskinesia. So pain in the morning, usually after a rest, or pain after rest in the afternoon. When I go down that track, I'll ask them actually just lead straight into it. It hurts in the morning after you get up? Yeah, it does. Does that, and then they'll go on with a bit of stuff, and then does it hurt at night time too? You just get a chance to ask that one. Oh, yeah, and then the next thing I ask is, does it hurt the same after rest when you move in the morning and the evening? To give an idea of how chronic the things become. The reason you want to know how chronic it's become is because what you really want to be sharp about is nerve entrapment. Those patients who have some form of nerve entrapment involved with their heel spur syndrome is where I'm leading here. Because they're the tough ones. They're the ones where, I would say, at least 80% of patients are at least 50% better at 2 to 4 weeks after our normal first line of treatment. Not just orthotics, all the other stuff that you're going to do. And not shockwave, not cortisone, all those things. I'm talking about all the standard things that you would do. Orthotic stretching, non-steroidals, proper shoes. Anything else you do in that first line? What else would you do besides that?